Happy Hump Day. Well, when I record this is Hump Day. Welcome back to Diabetic Book Files. I'm Dr. G, where we don't just tell stories, we decode them. So today's case, or what we're going to talk about today, this isn't just about lies. This is about misdirection because what looked like a routine diabetic foot ulcer turns into something more dangerous, a case where every answer led to the wrong question. Okay? So let's do something quick. Let's say a 62-year-old patient walks in with a plantar ulcer under the first metatarsal head. Nothing unusual, long-standing type 2 diabetes, peripheral neuropathy, elevated hemoglobin A1C. All these are classic lines that you've heard before. It just showed up one day. So everyone in the room does what a clinician are trained to do. We pattern match, right? Pattern match. So pressure, neuropathy, glucose control, right? Case closed. Nope. The problem is some of the most dangerous wounds in diabetic foot care are the ones that look predictable because predictability breeds assumption. And remember what assumptions or assuming does? It makes an A out of you and me, right? That's what they say. That's what assuming does, right? And assumptions are where we miss everything because this is not just an ulcer. This is a layer field hiding behind normal labs, decent shoes, and a story that almost made sense. So today we're going to do something different. We're not just treating wounds, we're investigating, like again, and peeling back each layer, challenging every assumption, and exposing the hidden culprits that turns a simple case into a perfect storm. So, this is not just a case, this is about diagnostic traps, clinical illusions, and a reminder that diabetic foot care, what we see is almost never the full story. So, let's get into it. So, first twist. The patient insists, my sugars have been fine recently. I've been checking my feet. I wear good shoes. Labs confirm recent glucose logs, mostly within range, no recent infection spikes. So now the first assumption cracks are if the glycemic control is acceptable, why is the ulcer progressing so aggressively? We're going to talk about different culprits. One, culprit. So the ABI is normal, so everyone relaxes. But the toe pressure tells a completely different story. The toe pressure for this patient is severely reduced distal perfusion. They have dampened waveforms and a delayed capillary reform. So the culprit wasn't macrovascular disease, it was microvascular collapse from long-standing diabetes and endothelial dysfunction. So the foot looked perfused, but it wasn't healing perfused. Okay, so the hidden culprit in this one was microvascular damage. Next, initial story for this one. This is our second culprit. New shoes cause a new pressure point for a patient. So the patient brings in shoes. They're proper width. The offloading insert is present. There's no visible deformity inside the shoe. So the shoe theory collapses. But then something subtle is noticed. The insole shows a symmetrical wear pattern. So what's the hidden culprit when you see that? The gait culprit. So the patient actually had an old knee injury, unreported. So they developed this external rotation of the foot during the gait. There is increased medial forefoot loading. There is subconscious offloading of the lateral knee because secondary to pain. So the real culprit became the compensatory gait mechanics from a remote orthopedic injury that the patient never mentioned in past before. And the ulcer site wasn't random, it was a biomechanical landing zone of compensation. Next, we have a wound that looks has mild slough, minimal erythema, not overly infected. So, initial impression is the wound does not look infected. It's just chronic. And I hate when people say that. But this wound probes the bone is positive. So, and it has a subtle odor, which is present under debridement. So, what is our hidden culprit in this one? So, cultures initially returned normal skin flora. I hate that. But a repeated deep tissue cultures sampling showed polymicrobial colonization, anaerobic present, and mature biofilm architecture. So the culprit wasn't an acute infection, it was a silent biofilm ecosystem suppressing visible infection signs. So antibiotics alone were never going to fix that. Our next case scenario patient, clinical close assumption the patient is compliant, non compliant with offloading. So the patient insists, I barely walk anymore because it hurts. So this is a contradiction that appears. Then we use a pedometer data is revealed and surprise the patient isn't walking excessively. They are standing statistically for long periods of time in the kitchen while cooking and caring for their family. So what is the hidden culprit of that? Static pressure disease. So it isn't about walking, it is about prolonged standing, repetitive plantar load in one position, no pressure redistribution. So this created a continuous focal ischemia under a still foot. So the real culprit wasn't activity, it was immobility in disguise. Next culprit for us. We have a patient that had inflammatory markers. The white blood cell count was normal, the CRP is mildly elevated, and there's no fever. So, infection severity was underestimated for this patient. But clinically, the wound breaks down and there's subtle cellulitis signs creeping proximately. So, what is the hidden culprit in this? Immune paresis in diabetes. So, the patient immune response is blunted, and that happens quite often in diabetes. So, because of the neutrophil dysfunction, the delayed cytokine signaling, and the poor inflammatory visibility, the infection is clinically severe but biochemically quiet. This is why diabetic foot infections often look less sick than they are. Immunoparesis in diabetes. Next, let's say we have a patient, their medication review reveals they are on long-term diuretics for hypertension, an ACE inhibitor, and there's no recent medication change. But labs show elevated hematocrit trend and borderline renal perfusion markers. What's the hidden culprit of that? Hemoconcentration and perfusion shift. So the diuretic, like we spoke about in the hemoconcentration episode, the diuretic effect causes mild hemoconcentration, reduced microvascular flow efficiency, and decreased tissue oxygen delivery. So the final piece clicks into place that this wound was being starved at a microcirculatory level, while everything else looked quite stable. So let's combine all the layers because, like I always say, diabetic foot ulcers are not simple. It's a multi-layer convergent event. So primary drivers when it comes to the diabetic foot ulcer, microvascular ischemia, biomechanical compensation, and then static pressure overload. Whoa, we're talking about this patient that we talked about just now. And the accelerators were biofilm infection, immune suppression, as well as subtle hemoconcentration from diuretic use. And the masking factors were they had normal vital signs, minimal inflammatory response, and misleading ABI values. So this case, because we went through all these different hidden culprits on this of the same patient, right? So this case teaches us something critical that diabetic foot ulcers are rarely caused by one thing. I mean, after you see how many episodes there are, yeah, that's a given. Diabetic foot ulcers are never caused by just one thing. They're caused by system stacking failures on systems. So until one small break becomes visible on the surface, but a lot of times it's bubbling under the surface for a long time. And what looks like a simple ulcer is often biomechanical, vascular, infectious, as well as metabolic intersection all at one point. So in closing, when we asked what caused the ulcer, the answer was not diabetes, the answer was not shoes, it was infection or trauma. It was the perfect storm of hidden contributors finally surfacing in one location of weakness, which is the diabetic foot ulcer area. So that is the real danger in diabetic foot care. It's not what we see, it's everything we assume that we don't need to look for. So that's why you have to do comprehensive medical evaluations on patients who have diabetic foot ulcer. Even if they have a callus, full evaluation, okay? Because prevention is better than cure. So this is Diabetics with Files. It's like almost 1 in the morning. But yay, happy hump day. Hope everybody's doing well. And take care of your feet because they take care of you.